We'll be discussing vomiting and diarrhea and the approach to the management of dehydration. So let's assume you're a doctor in the emergency room and a nervous-looking nurse comes to you and tells you about a 2-year-old child who was brought in by the mother because of 2-day history of vomiting and diarrhea. She tells you that the child is whimpering and appears tired. Now, your first job as an emergency room physician is to figure out if the patient has a severe illness or a mild illness. If it's mild illness, then you have the time to take a full history and examination before you start the treatment of the patient. However, if it's a severe illness, then you will have to assess the airway, breathing, circulation, also known as the ABCs, before you continue on specified treatment. So if you recall how I presented this patient, there was a few words that I used specifically to let you know what kind of patient we're dealing with. First, I said that the nurse was nervous. Anytime we talk about a healthcare professional and they appear nervous, should let you know that we're talking about a severe case. She also says that this is a 2-year-old child, so it's a young child who's had vomiting and diarrhea for the past 2 days. And she said that the child is whimpering and appears tired. Every one of these is an indication that I'm trying to tell you that this is a severe patient. That means we're going to be assessing the ABCs before doing a full history and examination. So we start with an ABC assessment. When we're talking about the airway, clearly if the patient is able to talk, then we have a patent airway. But even people who are currently speaking well could get worse, for example, if they have edema in the mouth or around the mouth, or foreign bodies, including vomit or blood. In general, any kind of noisy breathing is cause for concern, and the louder the breathing, the more concerned you should be. Regarding breathing itself, our goal is to see if the patient is working hard to breathe. Clearly, some good signs are having equal breath sounds and having a normal pulse oximetry. Pulse ox is the single most important vital sign for breathing. Even if the patient looks and sounds great, any hypoxia is an indication of a serious problem. If the patient is using any accessory muscles for help with breathing, this is a sign that the patient has a breathing issue. Lastly, you want to check for circulation. A quick look at the patient will tell you if they're perfusing well. If they have a good mental status, then they are perfusing their brain well. If the skin is pink, then they're perfusing the skin well. Peripheral pulses are very, very important. Think of it this way. A patient who is awake and talking to you obviously has a carotid pulse, and it must be perfusing their brain. But peripheral pulses tell us if they're perfusing the periphery well enough or not. We also want to look at their vital signs. The heart rate and blood pressure are particularly important indicators of circulatory collapse. If the circulation is impaired, the first thing we have to do is establish IV access. We always try to get the largest bore catheters we can into a patient, and this may be more difficult in children than it is in adults. And if you cannot get IV cannulas in quickly and easily, then just go on and do an intraosseous injection. It's much safer, it's much cleaner, and it's much faster, especially when you're dealing with resuscitation. So once we've established IV access, our next step is going to be to resuscitate the patient. Now remember that we've already made the diagnosis that this patient has a severe illness. That means we're trying to save this patient's life. And the resuscitation of his circulation is going to require the use of a fluid bolus. For our purposes, a fluid bolus is always normal saline, which is an isotonic crystalloid fluid, and the volume given is going to be 20 ml per kilo. This is pretty much standard across the board for all patients who come in with dehydration. So if you have a 15 kilogram boy, he's going to receive 300 ml IV fluid bolus. How fast do you give that? Remember, we're treating a patient to save their life. That means we have to give them that fluid as fast as possible. The books will say give it over 20 minutes. That's just an indicator of how fast we're supposed to be giving it. Sometimes you can't give it faster than 30 or 40 minutes because it depends on how big an IV that you have in your patient. But give it as fast as you can. If you have 2 large bore cannulas and you can give it over 10 minutes, please do so. Remember, we're saving the patient's life. Now, just as a side note, you may see some people refer to a different kind of IV fluid bolus using Ringer's lactate, also known as Hartmann's solution or sodium lactate solution. Now, this contains more electrolytes that more closely approximate those in the human body. But in general, normal saline is much more readily available. It is very cheap. You will find a bag of normal saline, not just in the hospitals, but you'll find it in health clinics. You'll even find it at schools. So for all intents and purposes, a fluid bolus is normal saline, 20 ml per kilo, as fast as you can. And then you reevaluate your patient and decide if they need more fluid boluses. So what do we mean when we say reassess the patient? This is a chart that is in your book, in Essentials of Nelson, which compares the severity of dehydration. And if our patient presented in a severe dehydration and he already had tachycardia and the pulses were decreased and he had hypotension and increased cap refill and all of these other signs, it means that every time we give them an IV fluid bolus, we're hoping that some of these will improve and bring him closer to this sort of moderate area. So you give your patient your first IV fluid bolus, and then you're checking the heart rate if it's improving, you're checking the blood pressure if it's improving, and if it hasn't improved enough and the patient still looks like they're having all of these severe signs, then you give another bolus. And you may even have to give a third bolus. So if each of these boluses is 20 ml per kilo, you may end up giving the patient 60 ml per kilo. Once you've reassessed the patient and you're fairly confident that this patient is outside of the severe mode, meaning that you no longer have to continue resuscitating the patient with IV fluids, then you can start with the treatment phase of rehydration. Now, the treatment, when you're treating a patient who's dehydrated, you need to make up for the deficit that they've developed over the past 2 days. This is a patient who's had vomiting and diarrhea for 2 full days, so they've lost quite a bit of fluid. And the deficit, the best way to assess someone's deficit is to see if you have a previous weight. If you know how much he weighed before he was sick and how much he weighed now, then however much weight he lost is what is the amount of fluid that he's lost. So for example, if he weighed 15 kilograms before and now he weighs 13 kilograms, so he's lost 2 kilos of weight or 2 liters of fluid. Now from this deficit, the amount that he's lost, we've already given him a few boluses. If we've given him one bolus, let's say the 20 ml per kilo, and he weighed 15 kilos, so we gave him 300 cc's. So he's no longer he no longer has a deficit of 2 liters. He has 2 liters minus 300, which is 1700. And we give him that deficit over the next 24 hours. So 17 divided by 24, we start him on a drip of 70 ml per hour, and this covers his deficit. Now, if we don't have the patient's previous weight, as is often the case, then we're going to have to find a way to estimate how much fluid this patient has lost. And in that case, we use the signs and symptoms that we see in this chart here, the same chart we used earlier to define the severity of illness. By looking at this chart, you can see that, in general, infants who are currently severely dehydrated have lost about 15% of their body weight. So, if we estimate that the current weight is 13 kilos and he is currently at a 15% deficit, then by using a little bit of math, he's lost about 1.95 kilos or 1.95 liters of fluid. And again, we subtract the boluses that he's already received, and it ends up being that he's going to require 70 ml per hour for the next 24 hours to make up for his deficit. Now, once you've finished calculating how much fluid you have to give this patient in order to make up for the fluid that they've lost, you also have to start taking into account how much fluid do you have to give this patient just to maintain his normal fluid requirements. You have to remember that this patient has come in with vomiting, so you're not going to be able to let him drink any water or make up for any fluid lost that way. So you're going to have to give him what's called maintenance fluid. And there are several ways to calculate this, but the most commonly used one in pediatrics is called the Holliday-Segar method, which comes out to the numbers that are seen here. You give 100 ml per kilo per day for the first 10 kilos. The second 10 kilos get 50 ml per kilo per day. And then anything above the first 20 kilograms will get 20 ml per kilo per day. So if for our patient, if we estimate his weight to be 13 kilos, then the maintenance fluid requirement is going to be 1150 ml of fluid. If you divide that by 24 hours, then you get an hourly rate of about 50 ml per hour. So now that we've calculated how much deficit we have to give this patient to make up for what he's lost, and how much maintenance we need to give this patient in order to just maintain their normal fluid requirement, we can add these two numbers together and we can come up with a total hourly rate. Now notice so far we haven't talked about what kind of fluid to give. Sometimes that depends on the kind of electrolyte disturbance that the patient may have and the kind of dehydration that they may have. That's not the scope of this current lecture. I will be recording a future lecture to talk about the rehydration of patients who have hypertonic dehydration versus those who have hypotonic dehydration, because sometimes you give the deficit over periods of time that are different than the 24 hours that we've discussed here. But right now, for the purposes of this lecture, we're going to provide the deficit over 24 hours, comes up to 70 ml per hour, like we've calculated earlier, and we're going to give the maintenance that's required for the next 24 hours. And if that's 50 ml per hour, we add these two together and we get 120 ml per hour. And so far, now we've given the patient the fluid to make up for his losses, and we've maintained the fluid that he requires just for standard metabolism. Now, as the patient is in the hospital, if they continue to have ongoing losses, for example, they continue having severe diarrhea, you need to measure how much fluid they're losing and also make up for those. So you're going to be giving extra fluid based on how much ongoing losses there are. Again, that's not the scope of this lecture, but we will talk about it in future lectures. So to summarize, the approach is given in this table, also from your Essentials of Nelson. The initial goal of treating somebody with dehydration is to decide if they need resuscitation, and if they do, you're going to give them normal saline, 20 ml per kilo over 20 minutes. Repeat that as needed until you feel that they're no longer, their life is no longer in threat. And then you're going to calculate their total 24-hour fluid needs, which includes two different calculations, one for maintenance using the Holliday-Segar method, and one for deficit, which uses the estimated weight loss or measured weight loss. You subtract how much fluid you've already given through boluses from these requirements, and then you divide that by 24 and then infuse that on an hourly rate. The most commonly used fluid will be dextrose, 5% dextrose, half normal saline with 20 milliequivalents per liter of potassium chloride. There may be reasons why you'll have to use different liquids, and that's a lecture for another day. And if the patient continues to have any ongoing losses, please replace those as well. Measure and replace those. The reference for today's lecture is from Nelson Essentials of Pediatrics, particularly Chapter 32 in the 2019 edition, pages 125 to 131. If you have any comments or if you have any questions, please leave them in the comment section below, and I'll try to get to them in the updated lecture.